apply, they would go into Medicaid expansion rather than regular Medicaid. That is a key difference. We're not talking about shifting people who are currently in the Medicaid program over, because we cannot do that. We're talking about individuals who will, as they come in the door new, will come in and apply and come in through the Medicaid expansion route rather than regular Medicaid. Those individuals are reflected in rows 1 through 6 on your sheet. I will mention them very briefly. They all basically work the same type of way. So row 1, pregnant women. Right now, the state of Missouri offers Medicaid services to pregnant women up to 185% of the federal poverty level. In the future, if a woman comes in before she is pregnant, so this is somebody coming in before she is pregnant or when she is pregnant, they will go into the Medicaid expansion bucket. If an individual waits until she is pregnant and comes in and applies, we will still pay for her costs using regular federal match. That was a question that Senator Shaw asked. So if that individual is eligible for regular Medicaid when she shows up at our door because she's waited until she's pregnant to come in, she will stay on regular federal match, not expansion match. So it works basically the same way for these other categories. Breast and cervical cancer, ticket to work, spin down. Row 5, permanently and totally disabled individuals, that's the disabled community. And then row 6, women's health services. I'll briefly mention spin down. The way it would work, those individuals wouldn't be eligible for Medicaid, regular Medicaid in the future, because they would not have spent down. They will no longer have to spend down. They'll come in through the Medicaid expansion bucket. They haven't met spend down, so they're not eligible for regular Medicaid, to your question, Senator Shaw. So they would come in through Medicaid expansion rather than regular Medicaid. The permanently and totally disabled population, these are individuals who the state of Missouri serves who come in through the disability door right now, but never qualify for SSI. So they come in and apply for Medicaid and come in through the SSI route, but a certain group of them never qualify for disability. There is no reason for those individuals to put themselves through the pain of trying to qualify for disability if they can get health care coverage through Medicaid expansion instead. So instead of serving those people with 37% GR, we will be serving them under Medicaid expansion at a maximum of 10% state funds. So those are those categories. Finally, I mentioned the third bucket. You see on row 13, a savings for reduced recidivism. Those are people on probation and parole who currently we are not able to provide services for them because they're too expensive, because it would be 100% general revenue. So we simply don't have enough 100% general revenue to provide mental health services to individuals who are on probation and parole, at least not all of them. Department of Corrections has proof that providing mental health services reduces recidivism. They actually see that in their statistics, so they provided this information to us. If we can afford to provide more mental health services, we will have lower recidivism rates, fewer people going back to prison. So those are the broad 3 categories. And finally, just to briefly mention, there have been studies on states that have expanded that have confirmed these savings. So the most recent one, Deloitte, did a study for the state of Kentucky and discovered, yes, indeed, the state of Kentucky saw these savings. The difference is, as Senator Silvey pointed out earlier, the state of Kentucky did not set those savings aside. So they saw the savings, but they didn't put them aside in the trust fund. With that, I'm happy to answer your question.
Thank you. Senator Hsu.
I've got she actually.
Okay. Senator Shaw.
So, all of the people that are currently disabled right now would have to stay on the current spend down.
That's correct. If they're not, anybody who's currently in Medicaid The federal law is written that we have to continue to provide those services under the existing Medicaid match rate. Now, the little bit of difference with that you just mentioned there are spin-down clients. For spin-down clients, they have a regular process. So no, those individuals, if they don't meet spin-down, will suddenly become eligible for Medicaid expansion. So they are unique in that their eligibility is determined every month based on spend down. And if they're not spending down, then they're no longer eligible for regular Medicaid and they can come in through this door instead.
So is there a time period of when they would have to come in or not meet their spend down? I mean, do they have to like not meet it for a month or 2 months?
Each one of them might be different. I don't know if Jennifer can explain a little bit more how spend down works. I don't know if it varies by individual.
Jennifer Tidball, Department of Social Services. Senator, spin down, really the way it works is if someone walks through the door, they're eligible resource-wise, they're eligible asset-wise, but for they have too much income. So basically, the Family Support Division makes them eligible, but says to be eligible to receive Medicaid benefits, you're going to have to spend down a portion of your income. And that's looked at on a monthly basis. So we did ask for guidance from some legal guidance around, because we asked the same question you did, Senator, whether or not these individuals that perhaps 1 month they meet their spend down, 1 month they don't, but they've already kind of walked through our door and we said you are spend down eligible. We asked the legal question whether or not if they didn't pay their spend down a particular month, whether that be 200, whether that be 1,000, whatever that difference might be between what income they could be on full Medicaid, the 85%, and what they're making, would they be eligible for the expansion? We were told because, like Linda said, because spend down is a monthly eligibility look. If I'm an individual, I walk through the family support door, I've been told as a disabled person that, and I can't be on Social Security, so I can't be a dual, I can't be Medicare. So we're only talking about the people who are non-Medicare and are on spend down. So I'm disabled. If I'm told your spend down's $1,000, I might pay it. I'm just going to make this up, January and February, but let's say expansion would happen in March, I wouldn't pay it. And if I otherwise qualify for in that expansion population, then I would be
You would just
on the
move into
expansion.
So do you have that in writing from CMS?
I don't have it from CMS, but we do have something in writing from some legal staff that we retain from Washington that has connection with CMS.
And is this how it's working in other states? People, do they even have spend down?
Some other states have spend down. Not all states have spend down, but some other states have.
And
My
can you
knowledge
provide
is
us some
worth it.
documentation as to how it goes? So basically, what you're going to do is you're going to move every single person that's on spend down over to the.
No, Senator, not every single.
Well, I mean, every single person who's disabled under the age of 65, who is not otherwise on,
Which we have
Medicare.
Of our total population of spend down who pays in, which is about 19,000. I think we're estimating on our sheet about 280, 275 would fall under that definition of being able to qualify through the expansion. So the majority of those who are on spend down wouldn't qualify through the expansion because they're dually eligible. So the expansion doesn't allow for individuals to be covered if they're on Medicare.
Because they're on Medicare,
Yes.
because they are disabled and they've gotten SSI benefits, and
Yes.
so they're on Medicare.
Or
So-
they're elderly.
So you're only talking about, what's the size of the population that are dual eligible?
We've got on spin down, we estimate that over 19,000 are in the program and that 2,700 would move.
So you're still going to leave, most of the people who are disabled are still going to have to live at 85% of the poverty level, basically.
Based on the fact that the expansion language doesn't allow for us to cover individuals who are also on Medicare or
Right,
over
but-
65.
But the people that are come onto the program, they're going to be able to live at whatever their income level is, all the way up to 138, basically. Okay, what about the block grant question? We have been told in the past think I might have even worked with you, and we were told that the federal government, once you do a block grant, that there's a cap, and then you don't get to go above it.
I think Senator Silvey kind of addressed this. The administration currently is getting much more willing to work with states on creative ideas. I don't know if they would approve a growing block grant. Don't know. I don't have an answer to that question. Is it a possibility? Yes. Is it a certainty? No.
So, but our current understanding is that once you do a block grant, you're locked in, right?
Well, that's how past block grants have worked. So the TANF block grant, for example, is a set dollar amount. Child development block grant is a set dollar amount. I think what the senator is proposing here, Senator Silvey is proposing, is going to CMS and saying, in order for Missouri to be willing to do this, we would want a growing block grant, one that would grow with the medical CPI or some other feature. I don't know that they would approve that.
Do you have any documentation to indicate that they might?
No. I don't have any yes or no or indifferent.
Under the expansion, the state is responsible for 50% of the administrative costs of the new population. Where have you put that into your spreadsheet?
It is on the bottom of the sheet, in that very bottom, row 2. So those are the estimated. Obviously, the first year is higher because we would have some information technology costs. The cost comes down in year 2 because those one-time costs are paid for.
Okay, in every other state that's expanded, the population, the newly covered population was underestimated and turned out to be much higher, woodwork effect, and so on. How have you accounted for that?
We revised this model this year based on newer information. So all of our numbers have been updated. If you compare to last year, we, for example, are assuming more people will come in and need mental health services, et cetera. So we have reflected on this sheet some of the experience of other states. Do we know for sure that we're right? No. But we did try to the best of our ability, working with Mercer, to update, refresh all of our numbers based on newer experience.
Thank you. Senator Say?
Yeah. To me, it seems as though if we don't get an expanding block grant, that's all bets are off. Because we're going to have to tax the providers to make up the rules. Because we are going to have,
The
we
way
are going to have increases each year.
the way I've written the bill, they don't give us what we ask for, we don't do anything at all.
Okay.
What we say is status quo.
Yeah, because we can't.
Right. Because I'm not going to propose something that I believe to be financially unsustainable.
And that would be,
Yes.
okay.
Any other questions, Senator Hunter?
Yeah, question about the administration. So the state is eligible for half the cost of administration, and the figures I've seen is that nationally about the costs of Medicaid administration are about 7%. 3.5% of $2 billion is a lot more than the $1 million you have on the administration line under E2.
Let me explain. Well, number one, the state of Missouri always does things at less cost administratively than any other state, so we're cheaper administratively than average. Second, some of those administrative costs under this model would be borne by the plans, the managed care plans, because the proposal is that this would not be done through fee-for-service. So you are basically having.
Well, right now, managed care is only pregnant women and kids.
Correct.
You're assuming this whole program is switching to managed care?
For all of, no. This is just the
Okay.
expanded population.
You're assuming the whole expanded population is going to be going to
All of
managed care?
those who are healthy. The exception would be those who are medically frail. And those who are medically frail, so like the CPS and the ABA clients, are already largely managed by Department of Mental Health using 100% GR. And those individuals will now be in the Medicaid program. Mental health will do exactly the same management they're doing today, only we'll be able to earn 50-50.
So the mental health patients you offload onto the Obamacare Medicaid expansion, you're saying you're already paying for the administration of them right now.
Correct.
Now, of the $2 billion number you're talking about, that you're estimating that that's going to be
If you look,
22 million, gradually increasing to 29 million.
no, if you look in box B,
Oxby,
row 4 and 5, row 4 and 5,
B4 and 5.
those are the costs for services that would otherwise be provided through the Department of Mental Health. Most of those, at least in the first few years, are people they already know. And in future years would have been people who may have come into them anyway. So you're talking about let's go to the first full year, fiscal year 2017. In fiscal year 2017, row 4 is
So
325
where
million.
you're on B4?
B4,
B4, 325 million
And
for fiscal year
just-
2017.
just below that, 243 million. Those are individuals who are in need of mental health services, who would largely be already managed by the Department of Mental Health or the community mental health centers.
So of the, say, I hear the phrase the number $2 billion. So of the $2 billion, how much is going to be new enrollees?
You're talking about everybody in row 1, 2, 3, and 6. So $1.5 billion, $1.6 billion, $1.7 billion, and $2.4 billion.
So $1.7 billion of the 2.4 billion. Okay. So if I multiply $1.7 billion by 3.5%, again, I don't know how much more cheaply Missouri administers our Medicaid program than other states. But if we multiply 1.7 billion by 3.5%, we get a heck of a lot more than the $800,000 that you're showing for the bottom of the
Right, and that was the other thing I mentioned, Senator. Our managed care plans will be doing most of the administration, and those costs are already captured in box B. They don't have to be captured separately below. The administrative line on this sheet that shows up down below is just cost for Department of Social Services, for example.
So,
The managed care plan costs for administration are captured in box B.
so Senator, is it in your bill that the expansion population is all going to be covered by managed care?
Senator, this bill creates the ability for a joint committee of the House and Senate to completely rewrite Medicaid, so whether or not they are on managed care will be completely up to you and I.
Okay, but the budget directors, us, the administrative line here assumes that these are all managed care and that the administration costs of this are going to be minimal.
Well, the social services costs are what's reflected below. As I said, the managed care plan administrative costs are captured up above in box B. If hypothetically the legislature decided through this process that they weren't using managed care, then those administrative costs that we are otherwise paying managed care plans would shift over to the Department of Social Services line. Does that make sense?
That makes sense. Okay, thank you.
Thank you, Senator Schaefer.
Thank you, Mr. Chairman. Just a couple of questions. First, process question. For either one, I guess. The process by which the state would obtain a block grant, and Senator Silvey said that we wouldn't move forward unless we knew we had it. Is that approved before we formulate what the program looks like? You know what I mean? Because you're saying there's a joint committee after the fact. Is that just a general application of allow us to have a block grant to decide what it is, or do you go in with what you want to do first?
The concept that I have is that we go in and tell them, either you give us some flexibility or we don't do it, and not go in with a specific, this is what the committee has come up with. I suppose you could do it either way. Nothing would prohibit the committee from meeting while we're trying to negotiate for the block grant.
But you would have,
It wouldn't have to be. I don't anticipate the committee meeting, developing a plan, and then taking said plan and asking for a waiver. I anticipate going and saying, either you give us the ability to rewrite this or we don't do it.
but we would be voting on expanding eligibility before.
contingent upon the flexibility. If we don't get the flexibility, we don't expand anything.
Okay. I would imagine that they'll probably want, since, I don't know, this is never been done, they would probably want to have specificity as what we want to do and violate what they view to be the, what they want the program to look like. So,
Well,
is
I'm
that still-
completely open to helping write a plan. I mean, I came up with a plan last year and never really wanted a block grant, so this year I came with a block grant.
No, well, my question is about the block grant, is it written or is it not written ahead of time? That's basically my question. And I think what I hear you saying is that there's a general application for a block grant, it's not a defined.
Right, if we took them a proposal, it wouldn't be a block grant, it would be a waiver for the proposal.
Well, it'd be what we would do with the block grant.
Right, but it would be a specific proposal at that point, it wouldn't necessarily be a block grant. So I'm open to anything. I mean, I'm happy lining out a number of reforms that I think should be in the Medicaid system, as I did last year.
I would imagine the block grant, figuring out what the new program, as you said, from word one would look like, would probably take a fair amount of time. Yes.
Imagine it'd take a little while, yeah.
And the second question, I guess, Linda, for you is, in these numbers then, it looks like, is it assumed that the newly eligible age-blind and disabled are under managed care?
Under our proposal, no.
Okay, so right now they're not, under
Correct.
existing eligibility. Expanded eligibility under this proposal, age-blind and disabled, is still clearly not under managed care based on.
Right, the current ABD population would stay where they are, no change in this model.
Right.
Stay where they are, no change. The new medically frail population who do come in through Medicaid expansion, or those brand new people, we are assuming they also would not be managed care.
Okay.
Senator Shaw.
Just a follow-up. On box B lines 2 and 3, why would we have cost under the exchange and what is mental health works?
This is the governor's proposal that he has talked about. What you all would do would probably be different than this. The governor's proposal is that anybody who is above 100%, that 100 to 138, would be served through the exchange rather than through normal Medicaid. The state, through the Medicaid program, would pay the cost of those premiums. That's what this proposal is. And the Mental Health Works is that for small businesses, that those small businesses could provide insurance directly to their employees, and if they were Medicaid eligible, the state would help pay the premium cost.
And do we get a 90-10 match on those costs?
Yes.
So do you have anything in writing from CMS that says that that's, permissible?
Other states have done it.
Okay. Could you give us some documentation about other states that have?
Happy to do that.
Senator Unger.
Yeah, I have a follow-up question, but I think this is following up on Senator Schmidt's question, but probably more to the bill sponsor. So what has many times happened with these Medicaid expansions is that states have asked for a number of waivers. The state passes the Medicaid expansion. The headlines are State X expands Medicaid. And down the road, waivers are denied. What you're saying is that if our block grant request were denied, the whole bets off, no expansion happens?
Well, in most of the states that have done some sort of expansion and negotiated with CMS, the governor has gone and negotiated specific changes that they want. I think everyone understands that we are probably not of the opinion that we should give the governor the green light to go try to negotiate changes to our Medicaid program. So what I'm asking for is one waiver that mirrors the Rhode Island global waiver that they received, and say, if you want us to do this, we will do it, the legislature will figure out how to do it. We're not coming in asking for X, Y, and Z and only getting X. We either get the flexibility or we don't.
Okay. You made the statement that, quote, last year everyone wanted waivers. Was there a vote in the House or the Senate I'm sorry, everyone wanted block grants. Was there a vote in the House and the Senate, maybe in each year?
It actually the proposal that I wrote last year made it through a committee in the House and to the Rules Committee in the House. Senate, we had it on the floor for a little while.
Was it Medicaid?
Not last year, I'm sorry, 2 years ago.
2 years ago.
Before you arrived. I took that proposal to the floor of the Senate, and perhaps when I say everyone wanted a block grant, I should be more, maybe that was a little loose with my words, but when, in the inquiry that I had with Senator Lamping,
Sure.
he specifically said that a block grant is the way that we should go. My trepidation in that inquiry was I didn't want the governor to have the ability to completely rewrite the program without our input, and so I was not in favor of that.
Sure.
What I've come up with in the meantime is a hybrid. Yes, I will accept the idea of asking for a block grant, but I want the legislature to control how it's used.
So Senator Lamping said something favorable about block grants. Do you knowledge that Senator Lamping ever endorsed an Obamacare Medicaid expansion to 138% of poverty?
Well, you know, I haven't spoken to him about this, but I will say the day that I proposed this, he said on Twitter, this is 100% the way to move forward. So, without speaking for him, I'm going to look at his Twitter feed and find that.
But everyone is Senator Lamping speaking favorably about block grants.
Right, I mean, this whole proposal is a Republican proposal that started with Paul Ryan, when he was chairman of the House Budget Committee in Washington.
How did Paul Ryan vote on the Affordable Care Act, Senator?
The whole concept of block granting Medicaid originated with Paul Ryan as the chairman of the House.
Sure, no, block granting Medicaid, but Paul Ryan voted how on the Affordable Care Act?
Right, he voted the same way I have voted on straight Medicaid expansion, which is no.
Okay. Thank you.
Thank you. I'll tell you what I think we're going to do. We're going to not adjourn, we're going to recess and continue next week. That's agreeable to the presenter.
That's fine with me, Mr. Chairman.
I said I would like to testify. I hope someone. Okay, we'll adjourn, we'll pick it up next week. Right here, I hope I did not. I was hoping to get anybody medically frail or working. If they want to do a written testimony or something like that, it will happen the same way. But if they can come back.
So for anyone in the room who could not come back next week to testify in person, if they would submit their testimony in writing,
I'll make sure maybe get it, because I apologize to them.
thank you for your deference, Mr. Chairman.
All right, so my chief staff says that we have to adjourn recess, so we're going to adjourn, and we'll pick up next week here. Thanks.
Yes, I am. Thank you so much. Yes, please. Thank you so much. Appreciate it.